And histopathology showed chronic pancreatitis. They took a core biopsy from the head region, and patient remained symptom-free. And patient was put on pancreatic insulin replacement therapy and diabetes control. Patient improved on weight and on regular follow-up. This is actually histopathology at that time. You can see that it's all fibrous tissue, and there is no evidence of malignancy in that. And the patient again reported in 2012. And this time she presented with features of extrahepatic biliary obstruction. And at this time she had high counts. Her LFT was grossly abnormal, suggestive of biliary obstruction. And ultrasound abdomen showed a dilated bile duct. The pancreas was very poorly visualized because of the lateral pancreatitis. Dr. Jayanti, please.
In the first instance, what was the indication for surgery?
Pain. She has come with pain. She has severe pain, and it was recurrent pain. And for that reason, she was taken for surgery.
The LPJ was done for the pain.
Pardon?
The lateral pancreatic jejunostomy was done for the pain.
Yes, that is for pain. Any difference of opinion, panelist? Should the patient have gone for surgery or something else?
Yeah, I think the stone size was large here. That's the reason probably endotherapy is not possible. Surgery is the right indication.
Any difference? Anybody thinks medical therapy, endoscopy therapy would have been better?
Will the patient require a head coring because the stone is in that region?
Yeah.
And just by doing a jejunostomy would it help?
I think I agree with Mr. Jayanti. There is a little, this patient has been having no pain at all, and then suddenly the patient started having pain. Even initially the patient had dilated that.
Yeah.
The entire pancreas is atrophied. So I really doubt the role for surgery. If at all we do surgery, we should think of other things like
malignancy.
The change in the pattern of the pain, change in the diabetic status one, and so with respect to the fact that CA19-9 is less, one has to suspect whether this patient is going in for some other problem like a malignant change.
Yes, this was a very detailed discussion only. Patient was subject to surgery because 2003 onwards she was on regular follow-up. And she was having pain at that time also, but which was mostly controlled with simple medications, and she was reasonably okay. And 2009, she had severe pain which did not respond to medical therapy. In fact, we thought it is a malignancy. We did a CT scan, we did an endoscopic ultrasound, and we did not see any obvious mass. And then we gave the benefit of doing a surgery because there was a clinical suspicion of malignancy.
No,
and a head coring was, pardon?
The duct is maximally dilated. So what's the cause of mechanism of pain? It's maximally dilated.
That brings in an entirely different scenario. Cause of mechanism of pain in chronic pancreatitis. Actually, it's not the ductal obstruction alone. There are so many other mechanisms that I think now we are just moving on the case. Maybe at the end of the discussion presentation, if there is time, we will discuss on that. And this time she presented with biliary obstruction. And CA19 is 138, and CT scan showed a mass in the head. Dr. Shyam.
As you can see in this CT.
This is 2.5 years later. 2.5 years later.
You can see a very well defined solid lesion between the arrows where that is pointing. So this is a new finding. So this should strongly represent a neoplastic lesion.
So the question comes to you again. Does imaging help you to differentiate between an inflammatory versus a malignant mass, the pancreas?
Can go to the next slide. We have just displayed the summary of differentiating points. When we see focal mass, that is the primary sign of neoplasm. So can we differentiate from a focal inflammatory pathology? There are a few points given in this particular table, but there are many more points also. But ultimately, we may not be able to differentiate 100% in a given case. But these are the points, for example, if there is duct obstruction, we have to see the pattern of duct obstruction. If there is abrupt stoppage of pancreatic duct, or if CBD is involved, if CBD is abruptly stopped, that's a point in favor of neoplasm. And the amount of pancreatic duct dilatation compared to the amount of pancreatic atrophy. So if it is a very gross, more than 0.5, that's a point in favor of neoplasm. Double duct sign is in favor of neoplasm. And penetrating duct sign, where the duct passes through the abnormality. If the duct is preserved there, it's a point in favor of inflammation. And we look for enhancement when we do post-contrast study, whether it is CT or MRI. Decreased enhancement is a common finding, but it's more in favor of neoplasm. Though we see decreased enhancement in inflammatory area, but it will be somewhat patchy. And obliteration of fat sleeves around the vessels, that is more often seen in neoplasm. And there is a sign called teardrop sign where the shape of the SMV is distorted on cross-sectional imaging. That's a point in favor of neoplasm. Of course, secondary signs of malignancy like lymphadenopathy and adjacent organ invasion. And there is an interesting publication where they have mentioned the role of PET. And they have seen in this particular series, out of 6 patients where the neoplasm was proved, all patients showed increased uptake, FDG uptake. And in the majority of the patients where there was inflammatory mass, there was no FDG uptake. So the summary of this particular publication was, whenever you see FDG uptake, just be seriously considered for a neoplasm.
So you think PET scan has a role? Huh? We have been madam was telling about the tumor markers. Dr. Palanisamy, very brief, 1 or 2 sentences. You said tell whether there is a role for tumor markers in diagnosing chronic pancreatitis with malignancy.
There is a role in certain situations. As you are aware, the sensitivity and specificity is about 80 and 90%, and the values can be related to the tumor size at times. And the accuracy of small surgically resectable tumors is limited. And the other problem is the CA19-9 can be elevated in other malignancies. So these are the limitations by which we have probably looked at limitations. It can be useful in some situations, definitely.
Okay, I think we will go to the endoscopist, endoscopic ultrasoundist. Does it help EUS? Does it help in differentiation between a malignant versus a benign or inflammatory mass? And in the era of multi-slice CT, you think EUS has anything better to give?
I mean, EUS scores mainly in the ability to take a tissue at the same time as we do an examination. And most of the imaging features, as described earlier, were we differentiate inflammatory from malignant based on imaging alone. Up to about 25% may be misdiagnosed as inflammatory versus malignancy. The main advantage where EUS scores over is in the obtaining the tissue at the same setting and subjecting it to a cytology examination.
So you think there is a role for EUS and EUS scores over multi-slice CT, because multi-slice CT gives you excellent pictures and excellent morphology, but because of the FNA possibility, this is Shyam, anything to say? You agree to that? Chairpersons, be not silent, you also interact. Anyone in the audience, any comments? Very small decision, EUS is better. Yes, agreed, madam. No, but the problem with an operated a mass which is going to be operated, I think in FNA is better to be avoided, especially through CT or ultrasound guided. If at all you recur in this type of lesion, because you are going to do a Whipple's procedure, so even if you go to the duodenum, the tract will be taken away when you do the surgery. And this is actually the EUS which shows a mass there, and the needle is coming out and FNA was done. You got ample tissue, so it's diagnosed as adenocarcinoma. Dr. Surendran, when you suspect a patient with chronic pancreatitis is developing cancer, or clinically when you suspect a patient is having cancer?
Thank you. And this I think we already discussed. Any pain, there's a change in the intensity of the pain, or the change in the, if the patient is diabetic, the change in the diabetic management, like diabetes may become very high, uncontrollable, or even requiring more of insulin. All this thing I think one should suspect. The jaundice, again, the deeper jaundice, in fact we have done a study in our department, say that more than 8 milligrams is the cutoff in a multi, when we analyze, more than 8 milligrams, most often it is malignancy in our setting.
So in other ways, stable patient coming with a new change, like a patient who was having chronic pancreatitis, did not have pain, suddenly developing pain, that is why you suspected malignancy in the previous situation. And also development of biliary obstruction, especially with high levels of bilirubin. Agreed. And Paramnayagam, see, you know that in de novo pancreas, the yield of EUSFN is quite good, to the tune of 80% or even more. And in chronic pancreatitis, it becomes sometimes difficult. Do you think is there a real difference between doing EUSFNA in patients with CCP with mass and de novo pancreas, pancreatic malignancy?
The yield of the USFNA in the setting of chronic pancreatitis is only to the tune of 70 to 75%, much less than what is reported from a de novo CA pancreas. It may be related to the heart fibrotic stroma or visualization of the mass in the presence of a calcification. What we can try and do is to take more and more tissues, more passes to get more tissue, and then subject it to a good cytograph or cell block examination.
And the stones also sometimes obscure the mass. And this patient was subjected to Whipple's resection, and the operative notes shows that status LPJ, atrophic gland with fatty replacement, mass head of pancreas infiltrating the bile duct, multiple pancreatic and hepatic artery lymph nodes. The postoperative period is uneventful, and patient finally discharged. Next slide. I think the time is over, that's why. No, last few slides only. Stuck? No. The last couple of questions. Now, I want to show that slides, that's an operative specimen and all. It's okay. That's why I have the slides. But anyway, it's okay. The questions here I just want to ask is that Dr. Surendran, does intervention like a lateral pancreatic jejunostomy in patients with a chronic pancreatitis, does it alter the natural history of chronic pancreatitis, like exocrine, endocrine insufficiency, as well as development of malignancy?
This is actually $1 million question. Nobody knows the answer. There's a lot of controversy in this. But what we believe is, if you catch early before the entire pancreas is atrophied, maybe it does make a difference. That's what we have seen, but still the study is going on in our department.
When the patient is remaining asymptomatic, means the patient has no pain, then...
That's quite true. That's quite true. And when we pick up the patient at the atrophied stage, there is no point in doing any drainage procedure or whatever it is. But actually we are doing a study in our department wherein even if the patient is having young patients, pain of course, without pain we don't operate. We operate early, they seem to be doing better, but the literature is split. Like, there are both arguments for and against. But we do believe that it does make a difference in an young age with a good pancreas, with a severe...
Can I ask you a question? Out of your patients who have been operated, LPJ was done, and those group not operated, do you think the malignancy incidence is different in these two groups? No. Because at present there is no evidence to say that this... And one more question to all. Do you think that we missed a malignancy in 2009?
I think so. The reason is, whenever we feel that the entirely atrophied pancreas, the patient has pain, we have to think in terms of malignancy, number one.
Yeah.
And you cannot do a biopsy of the pancreas which will not pick up. And I am sure in this case, wherever there is a stone, over that you do head coring.
Yeah, it is
one
done.
little tissue, that would have picked up a pan in 1 and pan in 2 lesion. Probably that would have put us on a count.
And do you think what else we would have done in this patient?
You have done a US and the biopsy also.
Yes. Biopsy actually first 2009 there was no mass to do an FNA.
Yes.
And there were actually stones and dilate duct. And at that time the question was discussed whether we should go for a Whipple or not. But in a patient without any obvious evidence of malignancy and totally atrophied gland, and you do a Whipple, it is going to be, and even she has got fecal LSA less than 100. That means a very severe pancreatic insufficiency. She is going to have a very miserable time if you do a Whipple at that stage. We did not have any obvious evidence at that time that she had malignancy.
But would she have survived 2.5 years?
Pardon?
If it had been a malignancy?
2.5 years?
At that time, it would not have been a malignancy of this size.
Yeah.
You could have definitely picked up a dysplastic changes where we could have, probably that would have put us on guard. We would have diagnosed malignancy early.
The tissue, I just went back and looked at the tissue was quite good. They have done a head coring with whatever possible way, but you have to notice that there were some stones left behind the ancillary process. So I do not think that the first surgery would have done a thorough job by laparoscopy. So I was wondering whether it was an open surgery, things would have been slightly different. It is possible that there would have been a focus, a small focus of malignancy at that time, we don't miss that. So it's a theoretical possibility, but 2.5 years, almost 3 years, and she survived without a problem, and in fact her weight improved.
Dr. Matthew Philip to give away the mementos to the panelists and the chairpersons.